Good afternoon, everybody. So my name is Gomes Da Silva. I'm a specialist neurological physiotherapist at Hobbs Rehabilitation. I'm going to be talking now about why we need to use intensive treatment in the upper limb and how robotics might help us to achieve that level of intensity. Just by way of introduction, I lead the Intensive Neurotherapy Centre service for Hobbs Rehabilitation in Bristol at the moment. Before that, I was just doing specific upper limb intense work for Hobbs, but my longer background is in neurorehabilitation in the NHS. So I used to work at King's College Hospital in London, and I worked in all different areas of neurological rehabilitation. I'm also involved, obviously, in the AiBle project with Hobbs. Okay. Next slide, please, Sandra. All right, so I'm going to aim to go through some background to treating the upper limb after stroke, look at what the evidence base tells us about neuroplasticity, intensity, and robotic therapy, and how this might be applied to therapy of the upper limb. I'm also briefly going to touch on what kind of robotic therapy there is already in existence, and then we'll have a summary at the end and some questions. Next slide, please. Okay, so why the focus on the upper limb? Why do we need to focus particularly on rehab of the upper limb? Well, the upper limb movement is driven by our hand. So we know that we use our distal component of our arm to interact with the environment, to give us information and provide us meaning to tasks. This is a nice quote here from Napier on the slide. It's quite old now, back in 1980, but I think it summarises really well about the upper limb and the hand function. So the hand has many advantages over the eye. It can see in the dark, it can see round corners, and most important of all, it can interact with the environment rather than just observe it. So the hand and at the end of your upper limb, you're able to point, grasp, manipulate, reach. We use it for sensory identification. It's involved in communication, multitasking, and the result of all of those functions of our upper limb affords us independence. So without good upper limb function, our independence is compromised, which is why it's such an important rehabilitation goal. Next slide, please. So I put this slide in because I think it's a nice pictorial reference of the kind of activities that we are involved in, or we can be involved in, that utilise our upper limb. So the upper limb is incredibly complex. This demonstrates just some of the tasks that the upper limb can be able to perform. If we just think about some of these activities, it brings home the challenge of how difficult it is for us to rehabilitate people back to being able to use their upper limb for the functions that they might want to do. So in these pictures, we've got free movement of the upper limbs, we've got reaching, grasping and manipulation of objects. We've got bimanual tasks, such as opening the jar there, two hands working together. We've got dual tasks where the hands are doing different things, like playing the piano, playing the guitar. We use them for dexterity. So for example, the painting there, or the needlework, highly dexterous activities. We use them for stereognosis, knowing what is in our hand. The first picture there of an apple in the hand, you can feel and you can sense what the object is that you have in your hand. The upper limb is also important for orientation, body awareness, proprioception. It gives us balance and support. It's involved in gesture, communication and protection. And it's also involved in power-based tasks, strength and coordination. Next slide, please. So it's pretty clear then why we should be looking at upper limb rehab and why we need to focus on it. But unfortunately, the statistics are not good about upper limb rehabilitation after stroke. So these are just a few quotes about the recovery of the upper limb function after stroke. We've got, of those with reduced arm function early after stroke, 50% will still have problems after 4 years. Motor recovery plateaus after 6 months. Long-term disability is often associated with persistent impairment of the upper limb. Over 80% of strokes involve the upper limb. Only 12% of survivors obtain complete functional recovery after 6 months. And in comparison, almost 80% of stroke survivors are reported to gain walking ability. So it's a fairly grim picture, and the statistics bear witness to this as well. Next slide, please. But why is this? Why are there such poor outcomes in the upper limb after stroke? Well, I've just put a few reasons here. There are many more, but The upper limb is incredibly complex. There's a lot of complex movements that we need to use coordinated multi-joint movements to perform function. We need to use complex cognitive processing to activate our upper limb. We also require complex sensory information that drives the upper limb movements. We also need some level of intact corticospinal tract to allow us dexterous hand function, and often this is damaged after stroke. I think there's also a lower prioritisation of treatment. This is definitely true in the UK. I know there's an international audience here, so this may not be the case in other countries, but definitely in the UK, there is a focus in the acute setting after someone has a stroke to focus on gait, transfers, mobility, and the gross functional tasks rather than highly skilled ones involving the upper limb. And we've also always been giving our upper limbs an insufficient dose to actually make changes. Next slide, please. So why is dose so important? What have we been doing? We have to sort of start from the place of what have we been doing before we can look at where we want to go. So this is the reality of what we're actually doing in the UK. Again, this might be different internationally, so bear with me. This is a sort of UK-based slide, really. But in our country, in terms of stroke rehabilitation in the acute setting, the RCP, the Royal College of Physicians, advocates that we should be doing 45 minutes of therapy per day. And it's not defined, if any, how much of this we should be spent on performing upper limb rehab. This number is probably based mostly pragmatically when therapists were what they were delivering in the UK when the guidelines were written this 45 minutes rather than what we should be doing. But it's now been enshrined in the national guidelines, and it's become very much embedded into clinical practice in this country. The RCP has expanded this definition in recent years. I think 2016 was the most recent version of the guidelines, and they did recognise that this needed an expansion. They now have put in that we should be doing at least 45 minutes of each appropriate therapy every day at a frequency that enables you to meet your rehabilitation goals, and as long as you're still showing change from treatment. So there has been a recognition that this 45 minutes a day guidance is too rigid and possibly unhelpful in terms of delivering therapy in the UK. But the reality is, if we look at the UK SNAP data, we actually get closer to 25 minutes a day when it all boils down to what people are actually receiving. What goes into the audit is that 25 minutes of physiotherapy a day is what people are receiving. There is probably less in occupational therapy and slightly less again in speech and language therapy. So although we're only aspiring to a relatively low figure of 45 minutes, we're actually only delivering probably nearer to 25. There was a study in 2015, Hayward et al. They looked at what therapists were actually doing in their sessions, and they found these woefully sad statistics that the patients are engaged in active upper limb training for less than 4 minutes in a physiotherapy session, and slightly better of 11 minutes in an occupational therapy session. But in terms of the actual number of reps, repetitive task practice, the maximum they found was 32 reps. So we are underdosing hugely in this country. Next slide, please. So what do we actually know about the upper limb recovery after stroke? So we have this rule called the proportional recovery rule. This was defined in 2008 by Prabhakaran et al. And it's widely accepted as a sort of model of stroke recovery. So this rule states that 70% of your patients will recover 70% of their upper limb function. And these are likely to be the patients with less impairment immediately post-stroke. So there are approximately 30% of patients who don't fit this rule, according to the authors. And these numbers, this 70%, is based on the Fugel-Meyer score from baseline to outcome. So this is a predictive rule that's been widely adopted as well as what happens after the stroke. However, this idea has been challenged by a couple of more recent papers in recent years. So AiBle et al. In 2015 stated that the proportional recovery rule only applies to patients with intact corticomotor function, i.e. corticospinal tract of some description. And Hope et al. In 2018 looked back through the original data from this study, and they felt that the effect sizes were likely to be inflated in the original article, and they named their article Proportional Recovery Not So Proportional After All. So there is some debate about this proportional recovery rule, but it is largely accepted in healthcare that this is what happens. There's also ongoing debate about how long recovery goes on for after the stroke. Many authors will state that recovery only continues for the first 3 months after stroke. And if you look at that graph at the bottom there, you can see when you get to the 3-month stage, there's a drop-off in terms of improvement in impairment and function. This view also, though, has been challenged by more recent work, particularly the work of Nick Ward and the team at the National Upper Limb Rehabilitation Programme at Queen's Square in London. We'll have a little look at their study later in the talk. And they've managed to find changes even in chronic stroke, so well beyond that 3-month boundary. Next slide, please. So how do the principles of neuroplasticity help us to understand dose response and the intensity of therapy that's required in the upper limb? So learning in the healthy and the damaged brain is driven by behavioural, cognitive and sensory experiences. It's a combination of factors that enriches the learning environment. But the damaged brain changes the way it responds to learning, but it can still respond to learning. So in brain damage, you have a loss of brain connections, you have a cascade of changes that clear the debris straight after the stroke or the brain injury. You then have a remodelling of neuronal processes and production of new neuronal connections. We know that the damaged brain already starts reorganising after stroke. So, for example, you'll see people start to use their unaffected limb much more as soon as they've had a stroke. This is a form of a reorganisation process. But this process can be adaptive, it can be useful, or it can be maladaptive, and it can be not so useful. And this is where things like compensations might start to creep in with maladaptive reorganisation. Next slide, please. Okay, so this is my summary slide about neuroplasticity for sort of, in a nutshell, a very basic level, so not super technical, but this is kind of the way I've understood it. So this is trying to summarise the principles that underpin neuroplasticity and why it sort of should inform our treatment. So if we start at the top there, the picture of the clarinet, we've got use it or lose it. This is I think most therapists would understand this concept, that if you don't use your neural circuits, they're not engaged in activity, they will degrade over time. So a personal example there, I used to be able to play the Mozart clarinet concerto for my grade 8 clarinet exam, which was probably about 25 years ago now. But I haven't picked up a clarinet since then, not very much anyway. So I dare say I would not be able to pick up a clarinet today and play the same concerto. So I've lost the neural circuitry involved in that skill. Conversely, we know that if you use it, you will improve it. So the monkeys trained to take pellets from, in a controlled environment will increase the specific region of their brain that they have had to use through extended training. Specificity counts. So learning a specific skill rather than just using your limb to practice something seems to be required to produce changes in patterns of neural activity. So, for example, rats who work on skilled reaching tasks will achieve that task over time. There's the principle of repetition. Repetition of acquired behaviour is required to induce lasting neural changes. So once you have acquired the skill, you have to repeat that skill. For example, a tennis player, I thought I'd put Djokovic on there because he's quite topical at the moment. A tennis player who practices the same strokes over and over again, thousands of times in their training, will acquire that skill, and the repetition will allow them to execute that skill with great precision. And then we talk about intensity. So this is how much do we need to do? This is where the literature talks about looking at 400 hours spent on skilled reaching tasks, 400 repetitions, sorry, not hours, spent on a skilled reaching task has increased the synapse number in the cortex of animals. This has been applied to the human population, but the original research was in the animal population. Whereas they found with 60 to 80 repetitions, you didn't have the same amount of increased synapse numbers in the cortex. So we know we have to do a lot. There has to be quite an intense process. Time matters when we do the rehab. Early start is better than later. Plasticity is also driven by the importance of the experience, the motivation of the patient and their attention. So there's cognitive factors, not just a physical process. And then there's this idea of transference. Plasticity occurring in one set of neural circuits can then promote subsequent plasticity in others. So I like to use the Strictly Come Dancing analogy. Now, this might completely go over the heads of anyone who doesn't live in the UK, but for those who don't, it's a dance show where professional dancers are paired up with complete novices, and they have to learn to do professional ballroom dancing. So we see exactly this happening during that process of watching Strictly. You have repetitive task training, you have task specificity, there's motivation. It's a meaningful experiential environment for the person training. They do it for 10 weeks. They work every day, probably for about 8 hours a day on specific moves. And at the end of that, the improvements are obvious. They have learned a new skill. Okay, next slide, please. So if we just take a look now at the evidence supporting intensive rehabilitation approach for the upper limb. Okay, so next slide, please, Sandra. The first study I've put down here was the iCare study from 2016. So this was a large study in the US. I think it was 7 different hospitals were involved. There were 261 patients, and it cost about $10 million. So they were looking at a comparison of intensive repetitive task-oriented training compared with unstructured occupational therapy. So they did 30 one-hour sessions over 10 weeks was their sort of idea of their intense level that they wanted to achieve. So that was 3 hours a week that they were looking at. And they evaluated at 4 time points. They did baseline, the end of the therapy, 6 months later, 12 months later. And they found no significant differences between the groups. So if we look at that, the dose there, 3 hours a week, is not what I would class as intensive therapy. So I feel that this had a suboptimal dose, and that's probably why they didn't have a particularly helpful finding from that study. Next slide, please. So this is a study from the constraint-induced movement therapy literature. So this was the Excite trial in 2006, and again, another multi-center RCT over 7 sites. There were 222 participants in this, and they looked at CIMT. So by that, they defined repetitive task practice and shaping work with the hand, and they compared that with usual care. So the CIMT input was 6 hours a day, but only for 14 days. So not for very long, but very intense over that period. Their total was 84 hours of therapy. So we're looking at a much higher dose here. And they found clinically relevant and statistically significant improvements in arm function. And interestingly, they also had greater improvements in the CIMT group 12 months after a follow-up. So there was some level of sustained behavioural change in this patient population. Next slide, please. Now, this is another very high dose study. So we've gone from 84 hours. Now we're looking up to 300 hours with this study. This was Mckay Better in 2015. Again, another randomized controlled trial with a comparison of robotics, FES, and motor learning methods. So they did 5 hours a day, 5 days a week for these patients, but they only had 39 subjects. So it was not a big RCT. It was relatively small. And they did 12 weeks total intervention, so total 300 hours. And this was in chronic stroke patients, so more than 1 year following stroke. And they used 3 different interventions, but all the different groups, motor learning, robotics, and FES, all received the same intensity. So they found clinically meaningful changes on the Fugl-Meyer, and by clinically meaningful, I mean above 7 points, which is what most of the literature will tell you is a meaningful number. They had gains of 8 to 11 points on the Fugl-Meyer following this program. And so it shows that the intensity plus the intervention is the thing that makes the difference. All the 3 groups improved because they had a very, very high level of intensity. Next slide, please. This is another small RCT by Chow Han in 2012, a 32-patient RCT. And in this study, they were looking at 3 different groups being given 3 different doses. So they had 1, 2, or 3 hours a day, 5 days a week over a 6-week period. So Group C received a maximum of 90 hours of therapy, and Group A received a minimum of 30 hours, all over 6 weeks. They didn't use robotics at all in this. They just used motor relearning principles, task practice, active movements, strength training, etc. They found that the Fugl-Meyer improved after 6 weeks post-treatment. They had improvements in all 3 of their groups, but they had the largest in Group C, which was the largest treatment effect. But also they had good outcomes in Group B with the 60-hour group in Group B. Next slide, please. Okay, and then I've just put in here, this is not an RCT, this is outcomes from the intensive upper limb neurorehabilitation programme from the National Hospital for Neurology in London, Queen's Square. So this was Nick Ward, Fran Brander and Kate Kelly in 2018, published the results from their intensive upper limb rehabilitation programme. So they have set up a programme where they deliver 90 hours of therapy over 3 weeks, various different therapy settings. So there will be physio, occupational therapy, group therapy, bit of robotics, independent practice, all that kind of thing. So lots of variety, but sort of 7 hours a day, every day, these patients will attend this program. And again, they have seen a Fugl-Meyer average 8-point change at the point of discharge, which is 3 weeks after admission. And interestingly, they have also seen an increase beyond the discharge at 6-month follow-up, where the Fugl-Meyer has risen to 11 points. So these patients, again, have got some sort of sustained behavioural change where they are continuing to make progress in their own setting after the programme. Okay, next slide, please. So those are just a handful of articles. There are lots more, but those are a handful of articles, mostly RCTs, about the dose and intensity required for rehabilitation of the upper limb. So we can see from that so far that we know that the dose needs to be quite high. The lower dose studies don't show the same level of change. So there's evidence to support an intensive rehabilitation program in the upper limb through specific skill acquisition and repetitive task practice at a much higher dose than what we previously thought. So this gives us an opportunity for robotics and neurotechnology to help us achieve this. So the use of robotics can help us with repetition and intensity. It provides a level of engagement during repetitive task practice, gives the patient motivation and attention through using games or different VR interfaces, but it still needs to be rewarding and meaningful to help with new skill acquisition. If we think about plasticity still, we don't want to just repeat the task, repeat the task, repeat the task. It needs to be an acquired skill. But robotics also do not replace the clinician. I'm sitting here as a clinician who works with robotics. I'm not here waving the flag to get rid of therapists. Don't panic. Okay, next slide, please. So robotic therapy is not really a new thing. It's been around for quite a while. It's actually been written into the stroke guidelines in the UK that we should be considering robotic therapy. So why don't we embrace it more? These are just, again, from my own experience, these are the reasons that I've come up with. Some of the reasons that the first, obviously, is the cost can be prohibitive, and then you have a maintenance cost as well and a training cost to keep those staff members being able to use those pieces of robotics. It's seen as moderate to high risk in terms of a risky intervention, so people are not always keen to use it. The evidence is not compelling, and we'll have a look at that in a minute. But there's also this delay between science and research, making it actually into clinical practice. I think someone's looked at this, and they looked at it in a study, and it was about 14 years from the original research saying that we ought to be doing some sort of intervention to actually becoming embedded or possibly accepted within clinical practice. There's problems with space in departments to use robotics. There's a general skepticism, I think, amongst therapists and medical professionals that they're of any use. And there's a fear that maybe we will de-skill, we'll use them too much, and we'll lose our therapy skills. Next slide, please. So I thought I'd just go through, for those of you not working in the field of robotic rehabilitation, this is just a very brief run through of the sort of types of robots that we can use to help us achieve intensity. I've split them broadly into 4 types. So the first type is an end effector. So these robots rely on a single distal point of control to guide the limb. So these sorts of robots are beneficial to the patient as they give them freedom of movement and the opportunity to learn to find control whilst controlling only part of the limb. They're not suitable for everyone. If you have significant weakness, significant impairment, you might still need facilitation to be able to move these kind of robots. The ones that are shown here from left to right is we have, I think that's an in-motion machine at the end. The second one with the fingers and the plasters there is an Amadeo. And then we've got a Ryogo, and at the end with the string, the overhead gantry is a Diego by Tyra Motion. The next slide, please, Sandra. So the next kind of robot category is exoskeletons. So these are more supportive. These enable precise control of the upper limb and restriction of unwanted movements. And these type of devices control movements across multiple joints. There's controls in each plane of the movement. So again, here we've got, going from the left to the right, we've got the Handy Rehab by Fourier, hand robot there. The next one is the AiBle prototype from the AiBle work that they did before they moved on to this project. So this may be something like what AiBle might look like. Then we've got the Armio Power, and the hand at the end is called a Hand of Hope. There's also lots of lower limb exoskeletons on the market. I haven't gone into that. There's Exobionics, Locomox, Exoatlets, loads of different ones. Okay, next slide, please. And then we have assistive devices. So these are wearable devices that facilitate performance of actual functional tasks. So these are essentially functional orthoses. So you wear the device, you train to complete a task with the device in situ. You're not necessarily training the movement to be performed once you've taken the device off. We are looking at that with Hobbs, with Maya Pro, which is the first picture there at the bottom, as to whether or not we can gain a therapeutic effect once the machine is removed, once the robot is taken away. Can we get any lasting change? And we're sort of looking at that at the moment. So left to right, we have Maya Pro and My Hand in the middle, and a Myamo on the right side. Next slide, please. And the last type I've just put in is not robotic technology, but is sensor-based technology. There's quite a lot of things on the market that use Bluetooth or camera technology to identify where the limb is in space and then give you some sort of VR screen feedback or gaming kind of options. They often involve the use of Kinect cameras. This system that you can see there is the Pablo system, which we have here in Bristol. And this has sensors with gyroscopes inside, and these pick up movements that work in combination with other sensors to increase the accuracy, so the machine can understand where your limb is in space. Next slide, please. So I'm just going to move on and look a little bit at the evidence supporting robotic rehabilitation for the upper limb. We've looked at the intensity side, but what about the robotic rehabilitation work? Next slide, please, Sandra. Okay, so I started with this quite recent study, April from 2020. This is an upper limb robotic rehabilitation after stroke multi-center randomized controlled trial. It's got 247 participants. This was done in Italy in 8 different rehabilitation centers using subacute stroke patients, so not acute. And they looked at robotic versus conventional therapy. They did 30 sessions of 45 minutes a day, plus the robotics plus 45 minutes of the conventional rehab over a 6-week period. They used Amadeo, Diego, and Pablo, which is what we have here in Bristol as well. And that total hours over the program was 49.5 hours. Now, they found no significant difference between the groups, but they did find significant improvement in both of the groups. So they had 8.5 and 8.57 point improvement on the Fugl-Meyer at this level of intensity. So there was good improvement, but the problem of comparison, of comparing one to the other and saying which is better, they didn't answer that question. And you'll see this theme comes a lot into these studies, that there's quite a similar model of research. Okay, next slide, please. This is a smaller multi-center RCT, 127 participants from Albert et al. In 2010. And they looked at robot-assisted therapy for 36 hours over 12 weeks. So it was only 3 extra hours per week that they had on the robots. And they, again, had a robotic intervention group compared with a conventional treatment group. And again, they found no difference between the groups. But they did find a small improvement on the Fugl-Meyer, only 2.17. But that is not enough to be clinically significant or meaningful to the patient. It's a very, very small increase. So again, it was quite an underdosed study. 3 hours a week is not what I would call intensive therapy. And they actually found better outcomes in their regular intensive therapy group than they did in the robotic study, purely because I think it was just underdosed and wasn't a very well designed study. Next slide, please. This is another more recent large multi-center RCT, the Rattles Trial. This is robot-assisted training for the upper limb after stroke. This is done in 4 centres but has 770 participants, and this was published in 2019, so it's quite new. Again, this was a little bit of a pragmatic study. They did what they could do rather than what they aspirationally wanted to do potentially. So they added in, you can see the number here, the 45 minutes come from the guidelines probably. They added 3 times a week of 45-minute sessions in addition to the usual care over a 12-week programme. They had a really broad inclusion criteria of strokes between 1 week and 5 years post-stroke, so that's quite difficult to then compare the outcomes as well. Again, they compared robot therapy with usual care, and then they had an enhanced therapy group as well. And so if you do the maths of how much they did in that 45-minute sessions, they probably did, it looks like they did 5.5 hours per week of total of therapy. So again, it's not particularly high dose. The high dose studies are looking at 15 hours or 10 to 15. And they had disappointing results. They had a negative finding. They basically came out and said it's not particularly helpful, which again was not very helpful for the community of us working in neurotechnology. But they did acknowledge that they needed to use much larger doses to see changes. So there is this kind of recognition in the discussion that maybe the dosing was not correct. Next slide, please. This is a systematic review in 2018 by Ferreira et al. And they looked at 38 studies in the review, and that was 1,174 participants. And their conclusion was that robot therapy has a small effect on motor control and medium effects on muscle strength. Again, they concluded that the low treatment dose in some studies may negatively influence results. So there is a theme here where people are starting to say the same thing in their discussions and conclusions. Next slide, please. Huang et al. In 2012 looked at finger robotic intervention in subacute to chronic stroke. This was a prospective RCT of efficacy. They did 4 weeks, 20 sessions, 5 days a week, again, 45 minutes in duration. The control group strangely received half the amount of the robot therapy group. That's just how they decided to do the control. It's yet another comparison study of robotic versus not robotic therapy. And again, they found improvements in both groups, only on some of the outcome measures, but not all of them. I think they had improvement in the Jebsen, the hand and wrist portion of the Fugl-Meyer, and pinch strength. But there wasn't a difference between the groups. Next slide, please. And the last one I'm going to look at is just to say that there's also been a Cochrane review into electromechanical and robot-assisted arm training for improving activities of daily living, arm function and arm strength. So they reviewed 45 trials in this Cochrane review. This involved 1,619 participants. Their conclusion was that people who receive electromechanical and robot-assisted arm training after stroke might improve their activities of daily living, arm function and arm muscle strength. So a little positive finding, but not a huge amount of positive finding. They also concluded that the quality of the evidence was high, but there was too much variety in intensity, duration and the type of treatment used to draw conclusions. So there's work for us to be done to look at the right kind of dose in robot therapy. There is starting to be a general recognition from authors and reviewers that the dose used in many studies is not enough to affect change. Lessons should be taken from the upper limb intensity literature and applied to robotic studies that we need much larger doses. And rather than repeating the same study design of comparison of robotics versus conventional therapy, we know both of these work. This has been shown time and time again. We need to instead be looking at high-dose studies comparing different types and applications of robot therapy to inform our clinical practice going forward. We probably need to move away from RCTs. I think Rosalie will be talking a bit more about this in the next presentation, what other kinds of research we should be looking at. What we want to know is we want to know what kind of robotics work best for patients. How do patients best engage with the technology? How much therapy assistance is optimal? We know that technology in combination with high dose intervention works. So now we need to find out more about how best to use the technology to achieve the best outcomes. Next slide, please. So in summary, we need to be innovative with our treatment, both in terms of robotic therapy and conventional therapy. And we need to be embracing the principles of neuroplasticity and intensity to guide our interventions. Robotics will provide us an opportunity to increase the dose. We need to look a bit more as to how we do that most effectively. High intensity rehabilitation of all types is a gold standard. So it's the amount of intensity and what you do that matters. But we also, I think we can take from this that the evidence base around intensity should inform the future studies in robotics to make sure that there's a correct dose response to the intervention. Next slide, please. This is my final slide. All I'm going to say is I am a therapist. Robots, just a reminder, are used intensively alongside conventional therapy for the best outcome. So it's not a competition between conventional therapy versus robotic. It's about working with those two things in partnership and clinically reasoning why you would want to use a robotic as part of your treatment and what your functional goal is that you're working to achieve. Next slide, please. That is the end of my talk. So if there's time for any questions, I'll be happy to answer.